TopMedTalk.
Welcome back to Anesthesiology 2022 here in New Orleans. It is the annual meeting of the American Society of Anesthesiologists. We're TopMedTalk. We're here in the exhibit hall at booth 2245. I'm Desiree Chappell, your host, and I'm joined by my co-host, Professor Emeritus.
Professor Emeritus, thank you.
Solomon Aronson. Hi, Saul.
Hi, Desiree. How are you?
Good. It's going great, isn't it? We can say it's great. It is great.
It's been fun. It's a fun city. It's a easy place to have a good time.
Yeah. The venue, you can't beat it. We're right in the middle of everything. Some really interesting parades yesterday down Canal Street and through the quarter, which provided its own challenges, but lots of good people watching and parade watching for sure. Saul, TopMedTalk, for those who may not know us, what are we?
TopMedTalk is, we've been, in the space as a podcast outreach of evidence-based perioperative medicine, an entity that's existed for over 25 plus years now.
Yeah.
And TopMedTalk is the podcast arm of evidence-based perioperative medicine that's been around 8-9 years already.
Since 2017, and actually the launch of TopMedTalk was at that meeting in Boston. So we've been around for a bit. This is our 5th year at the meetings. The only reason where it hasn't been 6 is because no one was here in 2020.
Providing free educational content to anyone in the world who wishes to join us and download. And we are able to do that because we have sponsors who are graciously contributing to TopMedTalk.
Yeah, we could not do that without their support. We have platinum sponsors, Edwards Life Sciences, Medtronic. We also want to thank the American Society of Anesthesiologists. This booth would not be possible at all for us if we didn't have their support. So thank you so much. Wonderful conversations over the last 2 days. A variety of topics, variety of clinicians sitting down with us. We've been able to actually talk to some of the folks here in the exhibit hall and highlight new drugs, new technology that's coming out. So that's really, really been interesting. But I'm super excited to introduce our next guest, Dr. Evan Kharasch from Duke University. Evan, thank you so much for coming back and sitting down with us on TopMedTalk this year.
Thank you very much. It's really a pleasure to do this, to share information and join TopMedTalk. Thank you very much for the invitation.
Yeah, absolutely. Well, Evan, last year we were talking about the journal, and I do want to start off by talking about that just a little bit. But for those watching and listening today, tell us just a little bit more about your background as a clinician.
Sure. I'm a physician scientist. I'm a classically trained pharmacologist as well as a anesthesiologist. I divide my time between clinical care, NIH-sponsored research, and I'm the editor-in-chief of the journal, which is the official journal of the American Society of Anesthesiology, entitled Anesthesiology. And I've done that for a little bit more than 6.5 years, and we're extraordinarily proud of the journal. Our goal is to be the authoritative source of information that drives research and clinical care in the specialty. We publish what we call trusted evidence, discovery to practice. And that's information which may start in the discovery phase and make it all the way through to clinical practice. It's information which grounds the science from everything from discovery to clinical practice. And our goal is to increase the richness and the reach of the journal, continually improve the quality of what we publish, and continue to increase the number of people who can benefit from the information that we publish.
Yeah, absolutely. There's some great resources that I feel like you guys provide through the journal. Can you tell us a little bit about, for the membership and for those who are out there interested in being involved more with either a project that they're working on, a study that they'd like to publish?
Absolutely. Yeah. We have content which exists within the covers of the printed journal, and we have even more content that is in our website. We deliver content in a way to be as digestible and accessible to as many people as possible. Some may want content in small bits. Others may want to sit down and read an entire article or an entire issue from cover to cover. Yeah. So we have snippets, if you will. We have short summaries in our table of contents. We have, of course, the abstract of articles, but then we have a smaller version that says, what did we know before this article, and what does this article tell us that is new? And it's really to give people as many ways as possible to access the information. We also have a brand new, newly redesigned author resource center on the website. And this is for authors who are thinking about preparing manuscripts, hopefully submitting manuscripts to anesthesiology, which helps them step through the entire process. It guides them. Our instructions to authors has been expanded to try and give people as much information as possible while they're preparing manuscripts to really ease the process of submission and then hopefully successful peer review and publication.
Yeah, it's a demystification of the whole process.
Absolutely. We're a service organization in a sense, and we want to be of service to our authors as well as service to our readers.
Yeah. And Evan, also you're disseminating the message in other ways than the printed word, if you will. There's podcasts now that you are highlighting and other, if you will, dimensions to the journal that are new. Can you share?
Absolutely. I record every month something called an editor-in-chief podcast, which is about a 20-minute summary of about half a dozen articles. But we translate that editor-in-chief podcast into 6 languages. And it's available as a rebroadcast in those languages so that more people have access. For the majority of the articles that we publish, we have a sort of a one-frame diagram. We call it a visual abstract, which visually describes the content of the article. We do what we call an author podcast, if you will, where we'll sit down and interview the author of an article to find out sort of the insights. What was their thinking behind why they did what they did? And then we also feature one article every month as a 3-minute video, which is animated. And that presents the science as well. And these 3-minute videos are spectacularly done. So to the point of trying to make as much information as available and accessible as possible, that's what we want to do.
Yeah. And I know it's not the end-all, but the citation index of the journal has continuously ascended. Something I'm sure you're proud of. You want to share with us?
Sure. Our is sort of called the impact factor, is the trade name, if you will. And our impact factor has gone up year after year. That's one way of measuring the impact of what we publish. And there's also other ways as well. The number of article reads or downloads goes up 10% every year.
Wow.
The number of people who listen to our podcast is up 12% or so over the course of the past year. We have been listed in 133 policy documents in 9 countries around the world. So it's another metric of our influence, if you will, and our contribution to the specialty.
Yeah. Well, one more question about the journal. We'll move on to some of the topics that we wanted to discuss today. You were just mentioning before we started that the journal really does have their hand in the meeting here this weekend, anesthesiology. Tell us just a little bit more about how you work really hand in hand with the committee members and the whole organization to really partner on that.
Sure, thank you. The journal provides a lot of content for the meeting. This morning we had what we call the Journal Symposium. And that's a topic that changes every year. We set it about a year or two in advance. Hopefully we're predicting what will be hot 2 years down the line. We feature a couple of platform plenary presentations, and then we feature about a half a dozen research abstracts that are presented after those plenaries. So today's session was on delirium, something which is of great importance, of great interest. And we had a couple of very, very cutting-edge presentations today. This afternoon, we're having 2 sessions, what we call the best of. And the journal looks at every abstract that's submitted to the meeting, and we pick the very best 12 to 15 abstracts. And then they're presented at stand-up live research presentations.
Wonderful.
That's going on this afternoon. On Monday, we'll have what we call the Celebration of Research. And that's a long-standing tradition. We've done it for more than 20 years. And we feature presentations by 2 groups of individuals. One is the winner of the ASA's Excellence in Research Award. And the second is the winner of the ASA's Presidential Scholar Award, which celebrates the research accomplishments of a younger investigator. And this year, we actually have 2 presenters because we had 2 winners of the Presidential Scholar Award, 2 extraordinarily accomplished women scientists, And the committee
Wonderful.
could not distinguish between the excellence of these two people. And we said the only thing better than featuring one outstanding person is featuring two outstanding people.
Yeah.
So that'll be Monday morning.
And I congratulate women as well.
Absolutely.
Great. Yeah, women researchers are, we need to do everything we can to support that.
And
Definitely.
congratulate the future of our society because of young
Absolutely.
scientists.
Absolutely.
Absolutely,
So
yeah.
what we discovered yesterday is the standard of care today, and what we discover today will drive the specialty forward tomorrow.
Yeah, I agree 100%. Well, Evan, why I really ask you here is I would love to talk about opioid use. I know this is something, actually, you came to one of our EBPOM meetings, gosh, I don't know, 5 or 6 years ago. And this is where I really first heard about using methadone as really a first-line treatment in pain management and pain treatment in an acute care setting. And I just loved hearing that. We've had, future conversations, but there's a lot going on in the space. Regional anesthesia has completely taken off. You could tell better than I could about the number of articles that are coming out around opioid sparing or opioid free anesthesia. A lot of people think that it's a great idea. Is that nearsighted or a little short-sighted in the way we're thinking? Those are some of the things that I want to talk about.
Sure.
So.
Well, I think there's two key concepts here. The first is that what we do is grounded in the problem of pain. We know that half to 3/4 of patients who are having surgery will say that their pain was moderate to severe. Half of them will say that it was not adequately treated. We know that chronic postoperative pain affects 10 to 80% of surgical patients. These are people who have chronic lingering pain for more than three months after surgery. And we know that acute postoperative pain is the greatest risk factor for chronic post-surgical pain. So that's one frame, if you will, is the pain problem. And we need to address the pain problem. And we want to take care of patients' pain, not only just adequately, but spectacularly.
Yes, yeah.
The other aspect is appropriate opioid use.
Yeah.
And the use of opioids in the past 5 to 10 years has really been influenced by the opioid crisis, if you will. And the opioid crisis is overdoses due to opioids. There were 80,000 opioid-related overdose deaths in the United States last year.
Oh, gosh.
But the important thing to remember is that this is really not at all related to the use of opioids in the perioperative period.
Right.
And 88% of those opioids are due to deaths from illicit fentanyl. So the opioid crisis problem, if you will, has really become an illicit fentanyl crisis. And we don't want to confound that crisis or confounding the inappropriate use of oral opioids by primary care practitioners for reasons where they really weren't indicated with the appropriate use of opioids in the perioperative period to treat pain.
Right.
And the challenge is for us is to figure out the art and science of solving all of those problems at once.
That really is.
How's that going for you?
I was just going to say, well, I don't even know how to talk.
Well, there's job security
That's right.
because we haven't quite gotten there yet.
No, we're not. Well, let's just take and talk about the piece that we can, have some sort of influence in. We have presented several times during our EBPOM meetings and definitely had conversations about it, that in the world of anesthesia and surgery, that maybe the providers are the ones that have the problem with prescriptions and giving irrational doses, I guess, of opioids. What are your thoughts on that? Is it our problem? Is it because, what are the reasons that that's happening right now, you think? Or that it has happened in the past, I guess.
We know that there is over-prescribing of post-discharge oral take-home opioids by surgeons.
Right.
We know that only a fraction of those pills will be taken by patients. We know that a large fraction will be left over.
Yes.
We know that of those leftover opioids, the majority are not stored securely. We know that they're susceptible to being used by patients for reasons other than which they were prescribed. We know that they're susceptible to being diverted. We know that those diversions are susceptible to misuse, and some of that misuse will result in misadventure and potential overdose and death. The real challenge is how we right-size those discharge prescriptions. And there are approaches to this which I think may be effective. I was very fortunate to work with the Surgeon General a couple of years ago, Jerome Adams, in working on what turned out to be a rather long article about what we call the opioid ecosystem and the opioid pool. And this goes to the issue of these leftover opioids, if you will. So it's really not use per se, but it's really this pool problem. We know that for the past several years, state, local, federal agencies have all been focused laser-like in decreasing opioid prescribing. And that's good, but it's not sufficient.
Right.
And the issue is
not the only answer.
It's not the only answer. We know that opioid prescribing has decreased 40% over the past decade, but overdoses have increased 300% over the past decade. We know that from a simple economic perspective, strangling supply has never quenched demand. So we really need to work on the demand side of the equation as well as securing the pool and hopefully shrinking the pool. And we can shrink the pool by encouraging patients to give back unused opioids.
Yes.
We need better ways of allowing them to do it. We need to make it as easy or easier for patients to give back unused opioids as it is to get them in the first place.
In fact, there actually is a proposal right now, isn't there, through the government for a disposal method like a mailback program.
Congress gave the FDA the authority to make rules about how to make opioid returns easier. They did that many, many years ago. But it's only just recently that the FDA has issued a request for comment about how to do that better. We talked about the concept of mail-back envelopes, if you will. We need the concept of put information on how to take back opioids, or we said give back opioids, because take back sounds like work. Give back sounds much better.
Hey, it's all on how you present it.
That's exactly right. And how to do that easily.
Yes.
The ability to simply put in an envelope and then inactivate the opioids and get rid of them. Another approach is what we call partial prescriptions. There's been a law on the books since 2016, federal law, that enables what's called partial prescription filling. So, and this can be done either at the request of the practitioner or at the request of a patient. So, for example, a practitioner wants to write a prescription for 30 opioid tablets. But what they can do is they can check a box for what's called a partial fill. So the patient will get 15 tablets, and if they need more, they can get the other half of the prescription within 30 days, no questions asked, no additional cost. You don't need the permission of the prescriber to do this. But what this will do, it's estimated that by doing this, we can save 600 million opioid tablets in the general supply.
Wow.
In just a year.
Yeah.
So, Evan, why is that different than writing a script for 15 that is refillable once? And you know, I ask, isn't there still need for a cultural transformation of a patient to realize that pain is part of the recovery process, and to help us change the culture of a provider that they should be less intolerant of pain as being a consequence of the recovery process?
Yeah, that's a really good question. And we know that the U.S. uses 80% of the world's opioids. We know
that is a staggering statistic.
That pain is a psychological reaction to nociception. We know that those psychological reactions are dependent in part on culture and expectations. There are many countries where patients are told to expect pain after surgery and that it's a sign of the healing process, and therefore the more they hurt, the faster they're healing. Now, we don't have that kind of a culture
Interesting.
in the United States. And so it's how do we achieve this balance? We do need to do a better job of educating patients around what their expectations should be around pain. That soreness is part and parcel of a surgical procedure. Excruciating pain shouldn't be. So there's a little bit of a Goldilocks here. Not too little and not too much. And that's really the goal.
I got my booster. I got my second, my third booster, whatever. And I remember feeling terrible afterwards. And everybody said, that's good. That means your inflammatory
Right.
process. Isn't that sort of the culture of pain and recovery? The other thing that I wanted to ask is I do think, and please push back if you think this is a bad assumption, that the medical community is now more sensitized to their contribution to this endemic, and that we in general are addressing that. Now, how quickly we do it adequately is one thing, but we represent just one sliver of the problem of the opioid crisis, and I think though we were contributors, we're not the cause necessarily. Is that a fair presumption?
Oh, I might even be a little bit more plain spoken in the sense that I think the size of our sliver is really, really tiny. Anesthesiologists are very willing to take the blame for many things, and it's an interesting phenomenon.
How true, right?
We didn't cause the opioid crisis, and because primary care practitioners overprescribed oral opioids for reasons that weren't indicated, and there were adverse consequences, doesn't mean that we should stop using opioids appropriately during and after surgery. The key is appropriate. I think that surgeons are getting educated. They no longer send patients home with half-gallon jars of opioid tablets. Hopefully, the primary care practitioners are being educated. But for so long, there were many, many incentives to the primary care providers to overprescribe opioids. Insurance companies were doing it. The federal government was doing it. The concept in the name of practice efficiency was if somebody came into the emergency department and they had a problem that was related to pain, don't keep in the ED for several hours and try and deal with this. Just give them some opioids and send them out the door, because that was much more efficient from a practice perspective. We now know that was not in the long term beneficial, but it was efficient. And so over the course of the previous decade, we saw a massive expansion of the use of opioids. And then suddenly there was a massive strangling of the opioid supply. Well, patients who were on opioids looked elsewhere to get the opioids that they had been getting medically. And they turned to illicit sources. So that was a major problem as well. And right now, the amount of fentanyl, illicit fentanyl that's coming into this country is huge, just huge. Hundreds of thousands of pills are being seized every year. And unfortunately, that was simply a response to a demand. And so strangling supply doesn't slake demand. We need to focus on that demand side of the equation. And many of the deaths that were happening from prescription opioids have now been replaced by deaths from illicit fentanyl. So that's another problem that really does need to be addressed. But I don't want us to lose focus on the problem, which that is appropriately treating postoperative pain.
Right. And so, I mean, that's kind of a surgeon thing a little bit, right?
Yes.
So let's talk about the anesthesia part.
Sure.
Because this is where, as we travel around and we have our EBPOM meetings, other conversations on TopMedTalk, so many people are looking to do opioid-sparing and opioid-free surgeries. I mean, that is something we've included in our enhanced recovery programs, and protocols that we have, reducing opioids. And we know that's probably the right thing to do. Talk to me a little bit about whether that seems like the right answer or not. And, is the pendulum swung so far the other way that maybe we're not doing a good job or an adequate job of treating pain?
Or to coin your phrase, opioid sparing opioids.
Right.
Yes.
So it's a really good question. Opioid-free anesthesia was all the rage a few years ago. And I think that what we've now come to realize is that we took that pendulum a little too far. Many years ago, I wrote an editorial about the concept of fashion in anesthesia. In fashion, ties get wide and ties get narrow, and hemlines get long and hemlines come up.
Legs get wide.
and things in anesthesia come into and go out of favor as well. So opioid-free anesthesia was sort of the rage for a while, but what we've come to understand is that there has not been any demonstrated benefit to opioid-free anesthesia relative to what's called opioid sparing, or I like the term rational opioid use.
That is a
I went around and listened to some refresher course lectures at this meeting to see what people were saying about this. And the message that I heard consistently was that it's really opioid sparing or rational opioid use, not opioid free, because there's not a benefit to opioid free. It's feasible. You can do it. You don't have to do extra work, so to speak, to not give a drug, although you do have to find other drugs. And people were using 2, 3, 4, 5 other drugs in order to not use an opioid, but there's not been any demonstrated benefit of that. So I think that really what we've kind of settled on is the concept of opioid sparing or appropriate opioid use, not necessarily opioid free per se.
Yeah. So I've been working in North Star Anesthesia, the anesthesia group that I work with. We've been working with one of our surgeons in one of our sites, actually several other sites doing, but the one I'm involved in, with opioid-free spine surgery. And that's something that the surgeon was very, very passionate about. We live in Kentucky, and the opioid crisis is still blazing hot there, and we have a lot of chronic pain patients coming to have surgery. And so that was something that they wanted to trial and look at, and that they have. I think, to me, and now we haven't swung all the way back to using lots of opioids, but we're kind of getting into that sweet spot of rational opioid use. So I think that's great. But what it did when we first started saying, well, maybe we should try opioid free, is it made the surgeons more aware and made everyone more aware that, hey, we are trying to reduce this. And I think practice, because some of the early things that are coming out of this is that we did reduce opioid use, in hospital opioid use, and long term at 3, 6, 9 months and a year, we actually did reduce opioid use as well. That's a lot of provider dependent prescribing. And so I think it's really awareness that much of this has been affecting.
Absolutely. And there's, in the article that we wrote, we talked about the need for education. And there is a need to educate patients before surgery. It should really be part of the preoperative preparation, if you will, of educating patients about their expectations and what they can find. It's a matter of educating surgeons who are extraordinarily skilled in terms of dexterity, but they're not deeply thinking clinical pharmacologists. So they need better understanding as well. And frankly, the educators need to be educated, because there's now evidence that tests have been given to the educators, and frankly, they haven't passed the tests either. So we need to do a better job of talking about this and teaching about it in medical schools and residencies. And there really does need to be a better, deeper understanding of the pharmacology, the rational use, and how to appropriately prescribe so that there's maximal patient benefit and minimal patient risk.
Right. In a lot of the enhanced recovery protocols and things that are coming out for multimodal pain management, multimodal being like, let's throw everything at the patient and hit every receptor. A lot of people feel like that's very complicated. There are people that, in the hands of the right provider, actually there are benefits to the patient and patient outcomes. We've talked about the use of methadone as an opioid-sparing opioid and actually using it minimally with other medications, not in so much of a multimodal path. Talk to me just a little bit about that. I know that's some work you're doing.
Sure. Methadone is a long-duration opioid. The opioids that we tend to use a lot in the operating room, fentanyl, remifentanil, hydromorphone. Those are relatively short-duration opioids. They have a half-life of anywhere between half an hour and 2 to 3 hours. Methadone's very different. It has a half-life of 1 to 2 days.
Yeah.
And the idea around using a long-duration opioid is that if you give a dose of a long-duration opioid, you may only need 1 dose.
Yeah.
And it can last for a couple of days. We know that the risk period for opioid-related side effects is greatest during the first 24 hours after surgery. Well, if patients don't need additional opioids, they're not going to run into the risk of opioid-related side effects. So the idea is not moving more and more towards short-duration opioids, because we still have the problem then of untreated pain, but rather giving a single dose, maybe a little top-up in the recovery room, of a long-duration opioid. And there's now evidence to show in numerous studies that a single dose of intravenous methadone at induction results in 30 to 40% less postoperative pain, 30 to 40% less postoperative opioid use. And it's really the first thing that has been shown to have a benefit long after patients are discharged. We've done some studies, colleagues have done studies that have shown that after spine surgery, for example, in an intraoperative methadone, pain is less for 2 to 3 months after surgery. After coronary artery bypass grafting, there is a benefit for up to a month after surgery in patients who got methadone compared to other opioids. We've shown that in outpatient surgery, pain is less for 30 days postoperatively. Opioid use is half postoperatively in patients who got methadone compared to other opioids.
Evan, let me pause on that. And I don't know that you studied the mechanism of those observations. And if you have, please share. But why do you think that is?
It's a really good question, Sal. We don't know for sure. It might be that if we're doing a better job of taking care of acute pain, we're not going to see chronic pain. Methadone is a little bit of an unusual drug in that most of the other opioids that we use hit the opioid receptor. Methadone hits the opioid receptor, but it also hits another receptor called the NMDA receptor. It affects catecholamine reuptake receptors as well. So we don't know what the mechanism is, why methadone is so good. Is it just due to the fact that it's got a much longer duration of action, or is it due to some of these other targets, if you will, that it hits? It's a really good question. We don't know the mechanism. We just know the clinical outcomes right now.
Oh. It's fascinating, Evan. Thank you so much for walking us through this. I know, last question around methadone. When I hear IV methadone, not something I'm comfortable with, we see oral methadone, and that's for treating patients that come to us that are taking it for chronic pain. A lot of people are fearful, and this is one of the things when I've been exploring is that, if I give a medication's going to last 2 days, what bridges have I burned? And can I take, what can I do to take it back if there's problems? I mean, are those issues? I mean, I feel like those are barriers maybe to implementation and use of methadone.
Like any drug, we got to use the right dose.
Yeah.
Right. And I understand that there is concern that, well, if I give a drug that's going to last a long time, what about the risk of respiratory depression? Well, the answer is use the right dose.
Yeah.
And what we found, and others have found, that for same-day surgery, a dose of 10 milligrams, patients are pain-free.
Weight-based or just not necessarily?
Straight 10 milligrams.
Okay.
And patients are relatively pain-free, and respiratory depression is not a problem. In next day surgery, if you will, 23-hour overnights, the right dose is 15 milligrams at induction. And then in inpatients, it's 20 milligrams.
Okay.
And is it really that simple? No renal, liver, metabolic, considerations? It's just dose, not weight-based, not organ function dependent.
It's that simple.
Wow. Okay.
Okay.
And methadone is metabolized. The metabolites are not active, so you don't have to worry about active metabolites. It's eliminated about 20% in the kidney and 80% in the liver. If you have somebody who's in renal failure, you might want to think twice. If you have somebody who's in massive hepatic failure, you might want to think twice. But for the average outpatient, if you will, the average 23-hour overnight, 10 and 15 milligrams are very effective doses. They're very safe. We do studies, for example, where we simply say to the practitioner who's never used methadone before, give 10 milligrams, don't give any other opioids, keep a patient asleep with a volatile anesthetic or propofol, and it works like a charm.
Short and
Boom.
sweet.
There, I love it.
It's the phrase that I use with them is set it and forget it.
Yes, for sure. Evan, thank you so much for joining us again here on TopMedTalk. It's always such a pleasure to catch up with you.
Thank you, likewise. Appreciate
Absolutely.
it very much.
Good to
one
see you,
more,
friend.
So one
You.
more plug for the article that you did with the Surgeon General. Where can we find that?
It's published in Anesthesiology, and the authors are myself, Evan Kharasch, David Clark, and Jerome Adams, the former Surgeon General, and it appeared in the February issue.
All right. Well, we will signpost people to that on the
Wonderful.
podcast, so please do look out for that. And thank you for listening to Top Med Talk here at Anesthesiology 2020. If you've liked what you've heard today or anything else that you've been watching over the last 2 days, please do check us out at topmedtalk.com. That's all of our content is listed there. You can find the live stream and share with your friends if you're watching right now at live.topmedtalk.com. Thanks again. See you soon.
TopMed Talk. Thanks for downloading TopMed Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMed Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.